There's a talk I put together a while ago, and someone once asked me, they said, gee, you seem to do a lot of things differently than other people. Why don't you just talk about what you do differently? And it was like opening Pandora's box. I realized there were quite a few things. Some of these will be kind of like one-liners, but it's what I do differently than most others in managing strabismus and why. This isn't something I typically do. And as I said, this will be kind of eclectic, not quite one-liners, but it's not like one continuously related theme. Convergence excess or high ACA ESO, I don't do Fadens, and I know many people do. I can say it works. I can say the only studies that have looked at it show it's somewhat unpredictable. It's not predictably reversible. And I think as a general principle, if ever I have a choice between a reversible and an irreversible procedure, if they both give comparable results, I'll choose the reversible one. With a Faden, you look at a textbook picture, you look at it at the end of a case, you say, well, I could reverse it. I just go in and pull out the stitch. But when you go back on them, it's a complete crapshoot what you find. Sometimes everything between the Faden stitch and the insertion is atrophied and scarred down and worthless. Sometimes it looks just like it did at the end of the case, and you can work with that tissue anterior to the stitch and everything in between. But perhaps more importantly, there are other options that are better. And specifically, I'll talk about targeting the near angle. But I also want to mention that just logically, a Faden is illogical for this purpose. Now, it has a role for balancing adduction deficit in side gaze, but no one has been able to explain to me a mechanism other than the one that I'm going to show you as to why it should work in the primary position. So let's just look at the Faden. Here's a globe with a muscle, and it attaches up anterior to the equator, and the functional point of attachment then for rotation is this point of tangency at the equator. Now, the force a muscle, the torque a muscle generates is the force, how much the muscle contracts, times the lever arm. That's XY in this case. And if we just do a standard recession, we see we haven't changed the lever arm at all, unless we go posterior to the equator. But we have shortened the muscle back here, and that decreases the force. So decreased force decreases torque. Now with a Faden stitch, with the eye in primary, we've only shortened the lever arm this very small amount from here to X. But as the eye swings into the field of action of the muscle, this Faden stitch swings posteriorly, and we progressively, almost exponentially, shorten the lever arm. So the Faden decreases the muscle's action increasingly as the eye moves into the field of action. I want to apologize, by the way. I may be taking a sip periodically. My voice is getting a little hoarse. I would never do this in person, but that's one of the luxuries of Zoom, and I hope no one considers that disrespectful. I think you'll hear me better. This is a graph that Alan Scott did. It's a graph of the torque of a medial rectus in different fields of gaze, abduction, primary, adduction. And this line is the normal medial rectus. So as the eye swings into adduction, the torque increases. If we recess the muscle, that's what this line is, the curve is exactly the same, it's just moved down, it's the same shape. But if we do a Faden stitch, it's the same up to 7 or 8 degrees of adduction, and then it starts falling off, and at 30 degrees of adduction, it really falls off, a 10 millimeter Faden stitch. So you can see, if we're talking about operating on a high ACA ESO and we're talking about getting good alignment in primary, the eye's in the primary position here. And the Faden has contributed nothing to the alignment of the eye as classically taught. So what I do is I operate for the near angle in the full distance correction. No, it's not for the angle through a bifocal. Did a prospective randomized clinical trial of high ACA ESOs, had 21 Faden patients and 25 operating for the near angle. And at 6 months, 80% of the Faden patients had satisfactory alignment, and 100% of the op for the near had satisfactory alignment, as defined by the study. I won't go into details. Now, what was very interesting to me is, of that initial cohort of 25 that had the near angle surgery, and who were followed for 15 years. I had 20, I'm sorry, this is a typo. They were followed for 5 years, but the study ran for 15 years. 22 I had followed for 5 years. 19 of the 22 were within 0 to 8 of ET at the 5-year outcome, which is pretty good stability, operating for the near angle. And 13 of the 19 were out of glasses. And some of those that were in glasses were high astigmats or high hyperopes. Yet, so even though I just said the Faden doesn't contribute anything in primary, why does it work, even though it's unpredictable? This is my hypothesis. I have never heard anybody say anything different, anything that made more sense. And this is all I can explain the phenomenon with. So here's a muscle, and let's say we want to go 14 millimeters back for our Faden stitch. The eye's in primary, here's a medial rectus. 14 millimeters back on the muscle is point X. Now, what's not talked about, and the muscle's 40 millimeters long, that's a typical medial rectus muscle. In order to place the Faden stitch at surgery, I've got to pull that eye way into abduction for exposure. So here's the eye way in abduction, and now I've stretched this medial from 40 millimeters to 50 millimeters. Now, if I go back 14 millimeters in the muscle, I'm at this point, not point X where I originally was. If I put my Faden stitch in here, suture it, tie it to the globe, have the eye come back to primary, this tissue back here gets shortened, and I'm inducing slack, a recession effect posterior to the Faden stitch. So that, to me, is why a Faden does have some effect in primary, but the unpredictability lies in it's a function of how far I've abducted that eye to get the exposure needed to put the suture in. And that varies from patient to patient and even from eye to eye. Okay. Now, next thing, so that's operate for the near angle. Another subject, let me just move these over here. In general, I reject relying on papers that say plus or minus 8 prism diopters is a satisfactory outcome when you're reporting something. For intermittent exotropia, any long-term esotropia is not a success. Patient's diplopic. Any persistent exotropia, I'm not talking about the immediate postoperative period, is heading for a failure. Most of the patients, if they're 10XT at 6 months, they're heading for a re-op. So I think you need to tailor it for the condition. Congenital esotropia, that's when they first started with plus minus 18. I looked at a series of patients 118 patients that I operated on for congenital dystropia. And I looked at those that had at their alignment 6 months after surgery, which is when most people present their data unless they presented at 6 weeks. 24 of them were either ortho or a micro ET, so just the flick, you know, too small to really measure with prisms, 24. The majority were between 0 to 8 ET. And 10 were 0 to 8 XT. Now, these would meet, all of these would meet most people's criteria for success. Most studies on infantile dystropia says plus minus 8 prism diopters. So these 0 to 8 would be success. I looked at how these patients who were aligned this way at 6 months did at 5 years. 90% of the micro ETs were still good at 5 years. 80% of the 0 to 8, I guess it should be a flick to 8, were good. But of those that were small angle exos, only 20% still had satisfactory alignment. So it's not adequate to just categorically use plus minus 8. I recall when I say you have to tailor it, when I did one of my prospective studies on intermittent exotropia, I think it was the one where I compared R&Rs to lateral recessions for basic. I was really proud of myself. I thought I had really rigid criteria. I said any esotropia at all is a failure. Any manifest tropia of any amount exo is a failure, and I accepted a small foria. And I operated on this college student, and she was in the R&R group, and she comes in and she's perfectly ortho in primary. And I said, Holly, you're a success. And she was an R&R. She says, but the minute I looked the tiniest bit to the right, that was the eye that had the surgery, I'm sorry, yeah, to the right, she's diplopic. And I said, but you're a success according to my criteria. And she's crying. I can't drive my car. I can't see the side view mirror and all that. And I never thought of including range of single binocular vision, which was absolutely important. So there's a lot that goes into what our outcome criteria should be, but it has to go far beyond just plus or minus 8. Okay, under anesthesia, forced ductions, of course, we do those. We talked about those. But I want to talk about the spring back balance test. And this is something Art Jampolsky popularized. I said I'd mention his name a lot, and I do, especially with restrictive strabismus. So in the spring back test, you grab the eye at 3 or 9 o'clock if it's horizontal, and you slosh it around abduction, adduction, abduction, adduction, and then you let it go from a position, let's say, in this case, extreme abduction. And the eye is going to rotate toward primary, and you see what it springs to. Here it springs to close to primary. Then you do the same thing and release it from adduction and see where it goes. And you want to see if it's symmetric. If it's symmetric. If it's symmetric, you have eliminated the restrictive elements. But what is not talked about, either in any of Jampolsky's articles or talks, or even when I hear his fellows talking, is that this is not necessarily the end point for the surgery, because this doesn't take innervational factors into account. For example, let's say hypothetically, I had a patient with acute lateral rectus paralysis, and for some reason I had him in the operating room at day 1. I'd never operated on him, but just hypothetical, bear with me. If I did a spring back balance test, it would be perfectly symmetric because no contracture has set in, there are no secondary changes. Yet clearly that patient would need surgery to straighten the deviation that we have there. So the end point is not a symmetric spring back balance test. That's the end point of your dissection of restrictive factors. Doesn't assess innervational factors. Now, I want to introduce maybe a new concept for you, unless you've heard me talk about this. Here's a girl who has a muscle slipped in the capsule. She has a big left exotropia after medial rectus recessions and a markedly underacting medial rectus muscle. This is a dynamic scan. When she abducts the eye, the medial rectus looks pretty normal. But when she adducts, you see the very characteristic appearance of a muscle either slipped in the capsule or a stretch scar. This fusiform dilatation of the muscle posteriorly and thin diaphanous attachment to the globe. Okay, that's the slipped in the capsule. But there are many patients where I'd see something similar and I'd go in and I'd find the muscle's not attached to the eye at all. And here's an image of such a patient, and in a way it looks the same as what we just saw, but there's a difference. And this is something that my neuroradiologist has nicknamed the collapsed empty channel sign. This muscle is not attached to the globe at all. What happens is it slips back in the orbit, and the two opposing faces of orbital fat come together and create an interface that shows up on X-ray, on MRI. Looks just like connective tissue. Now, the difference is, in the collapsed empty channel sign, you will see this appearance when the eye is in neutral gaze, whereas the stretched scar or slipped in the capsule only appears this way when we're innervating adduction in this case. Okay, moving on. I don't expect to convince people to do this, but I use 2 sutures on recessions. I weave one from the middle to the end, lock it, same here, and then I put all 4 sutures in the sclera. I do it because it prevents central sag. I think that's important. It's a safety factor against suture failure. I like the idea, this is a somewhat related topic, for the surgeon to fixate the globe. So I sit opposite the muscle, I fixate the globe and suture toward my fixating hand. I think of suturing as a 2-handed procedure, and I don't expect to convince you to use 2 sutures. But if I use 1 suture for whatever reason, and if I'm not doing an adjustable suture, which I often do, I never use the cross swords technique. I suture this way. I fixate and I'll suture toward the insertion, toward my fixating hand. The dots represent the interscleral tract. They're fairly small. So you get by with only, 3-4 millimeters interscleral tract, and then I tie the knot here. Why do I do this? The cross swords was developed by Marshall Parks pre-vicral suture. He used to operate with catgut. Catgut was like wet spaghetti. The knot, it would not hold the first throw of a knot. It would slip. So he felt that he had to overlap the sutures, have these very long scleral tracts, overlap the sutures, and then he's tying them, pulling this way, keeps it from slipping back. Overlapping is totally unnecessary. A long scleral tract, in my mind, is riskier than necessary, and it's simply not needed. And the other thing with the cross swords, the way he did it, he would sit at the head and he'd forehand 1 suture and backhand the other. And I think that adds an added element of risk for us average gifted surgeons. But surgeon fixating globe is very big. Early on, Parks and his fellows did a study, but they never published it, when he started using the cross swords, where they at the end of the case, they looked with the indirect under the muscle insertion in every patient they operated on. And in something like 30%, they saw visible suture tracts in the choroid. I just think it's not necessary. Okay, moving on. You need a curved ruler on the tray. The geometry tells us that when your recession is more than 10 millimeters, the difference between a 10 millimeter chord and 10 millimeter arc becomes significant, more than half a millimeter. So people have devised these curved rulers, and they're fine. But if you don't want to buy them, you don't need them. There are three ways around this. You can split the measurement. If you want to do a 10 millimeter recession, just set the calipers at 5 and measure twice. And two chord measurements of 5 will approximate the arc measurement very closely. The pictures always show a nice round globe. And if you're fixating globe, you can just push it down and flatten it. You can eliminate the arc curve disparity. But what I really like is to use what I call a measuring suture. And that's depicted here. So let's say I want to recess a muscle 10 millimeters. I take a suture, an extra piece of part of my traction suture, whatever, tie a reference knot in it, and cut it to exactly 10 millimeters in length. Then I lay that on the insertion along the globe back 10 millimeters. And the back of that measuring suture is exactly where I want to make my needle track. It'll conform to globe of any curvature. It stays there. You don't have to make a mark and then hurry up and put your suture in before the mark fades or goes away. And it's a very nice, simple technique. When I do a spiraoblique tuck, I never use a tucker. It's a bulky, klutzy instrument. For people that occasionally tuck, they shouldn't have to invest in it. I find it much simpler to just use a hemostat and a hook. I put a hook under the tendon, pull it up, and just slide a mosquito hemostat down, clamp it, and then suture behind the clamp. It allows me to feel the tightness of the tendon as I'm starting to tuck it, and it's a very simple and useful technique. If I'm operating on a vertical rectus muscle, I make my incision just anterior to the muscle. I would never do this on a horizontal muscle. Shouldn't say never, but I don't. But it's ideal. It gives better exposure than putting it in the fornix. It's better with respect to anterior segment ischemia and patient comfort than doing it at the limbus. You have great exposure. It's completely hidden by the lid. So even if you get a scar you don't like, it's completely hidden. And I'd encourage everybody to do that. I just make the incision right anterior to the muscle. Now, there's a lot of talk about, for the inferior rectus, people observe correctly that there's a high incidence of non-adherence with that muscle, especially on a hangback or adjustable suture. And some people use non-absorbable sutures for the inferior rectus, and you can do that, and that works. But I like to avoid non-absorbable sutures when I can. The knot persists, it causes irritation sometimes, it erodes, and if there's a way around it, I like that. So I prefer for the inferior rectus the technique that I call the semi-adjustable suture. It was described, not popularized, but described by Annette Spielmann in France. And that's where you tack the corners of the muscle to the sclera with fixed sutures, intentionally bunching the muscle a little bit so it sags in the middle. That's going to allow you to adjust, which you'll see in a moment. And then I put my adjustable suture through the center of this sag tissue and bring it through the sclera in the usual manner. So these are all absorbable sutures. Or if you want to wear a belt and suspenders, you could use non-absorbable for these corners, and they are still a lot further from visibility and erosion issues and so on than if I put them at the insertion. And then when it comes time to adjust, you can pull the center of this muscle up. It's surprising. I have pulled that muscle up 7-8 millimeters to adjust it. The downside, and it is a downside, is you cannot easily increase the recession, but you can decrease it. And that's my standard for the inferior rectus. Now, this is my take on the reason why the inferior rectus doesn't adhere. It has a short arc of contact. This is a scan taken on a patient with Graves' disease 1 day after an inferior rectus recession using a fixed, the semi-adjustable suture. And here she is looking in down gaze. And you'll see with the muscle attaching here and the insertions up here, if this muscle was not fixed to the globe, if it was suspended, it would lose apposition to the globe. And that, in my mind, is the reason that the inferior rectus is so common to not adhere. Semi-adjustable obviates that. Okay. When I trained way back, I always learned that high ACE-AESOs need an executive bifocal. And I was broken of that addiction by this patient. Patient wore +5 sphere OU with a 250 ad. The mother came in with new pair of glasses, old pair with the executive SED. The new pair has a flat top, a D seg, shaped like the letter D on its side. And D segs can come as much as 35 millimeters wide, which is almost the full width of an infant's frame. But it's made differently than the executive, and it's much thinner and much lighter. Look at the difference in the edge thickness between the executive and the D seg. With these particular glasses, I measured with a 550 sphere OU, the D seg, the lens weighed 35 grams versus 60 with the executive, and the edge thickness was 6 versus 12 millimeters. Now, I think the flat top is important because if it's a round top, the opticians don't know where to center that if they're looking at the child with the eye in the esotropic position. So a flat top, I think, is important. Hey, this is something I kind of feel strongly about, that recessions weaken muscles, but resections don't strengthen muscles. They tighten muscles. And there's a difference. And in order to understand that, and this is important, and this in fact relates to the idea of when I talked earlier in the EXO lecture about selective surgery and the medials affecting the near and so on. To understand this, we need to review basic muscle physiology. This is an electromicrograph of the basic contractile unit of a muscle, the sarcomere. A sarcomere stretches from this black band to this black band. That's one sarcomere. And we're going to break that down. Muscles have two different forces. There's the contractile force, also sometimes called the active force, which is what is the force generated if I innervate the muscle? If I stimulate a muscle to contract, how much does it contract? That's its active force. And the second force is the elastic or passive force. Think of the muscle like a denervated slab of rubber band. If you just stretch it, the more you stretch, think of a rubber band or a spring, more and more and more resistance. The more I stretch it, the more that force goes up. That's the elastic or passive force. And muscles have both forces under all conditions. And when people talk about the length tension curve of a muscle, you need them to specify, are they talking about the length and contractile tension or elastic tension, or both? Both are important. So let's go back to the sarcomere. What is it made of? So this black band is called the Z disc, depicted in this diagram by the black. And this black thing in the middle is myosin, actin and myosin. Myosin is this structure with these knobs on the end. And the myosin filament is connected to the Z band by this yellow thing that looks like a spring. And in fact, it is. It's called the titin. There's its name, titin. And just think of that as a spring. And overlying the knobs on the myosin is this, which is the actin filament. So in the normal position of rest, the sarcomere looks like this, with the myosin spanning the gap between the actin, but the knobs on the myosin being adjacent to the actin filament. Now, when a muscle is stimulated to contract, the myosin, these knobs, literally walk along the actin like that to create a contraction. That's the active contraction. So what happens when we shorten or stretch a sarcomere? This at the top is a sarcomere in the normal resting position, and it's the configuration I showed you. If I shorten a muscle, what happens is it can only shorten so far. The actin's got to bump into the opposing actin filament, and the myosin doesn't have as far to go. There isn't as much actin that it can walk across. So we've weakened the muscle when we've shortened it. What happens when we stretch it? Now the myosin isn't overlapping with the actin, so it can't walk along the actin the way it does in the normal condition. And this titin is stretched. Think of a spring. So stretching and shortening alters both the elastic and the contractile force for the reason shown here. So let's look at the length tension curve. This is the contractile or active force. In the normal working range, here's the sarcomere at its normal working position. We have the maximum isometric force that the muscle can generate. As we shorten a muscle, think of a recession, the force drops off. But as we stretch a muscle even further than normal, the force drops off also. Interesting. What about the elastic force? That's just the spring. Well, it's zero when the muscle's just sitting there at rest. And as we stretch it, this rises exponentially. So what's the length tension curve of a muscle? Well, if you want to take both into account, it's biphasic. Here's the active, here's the elastic, and if we sum them, we see this biphasic response. So according to this, shortening a muscle clearly weakens it, but stretching it, at least a small amount, weakens it also. That's where down here, until we're over here. And then when the elastic force really takes off, the force goes up. So the question, small resections may actually weaken a muscle. It's a little more complicated than that, but it's not as straightforward as we thought. So resections tighten, they don't necessarily strengthen. And quoting Art Jampolsky, the truth shall set you free, free from colleagues, free from friends, and free from other unexpected things. Let me. Few technical things about how I am in the OR. I do not sit at the head of the table. I think that's a ridiculously handicapping procedure. I actually move around a lot with a practice of complicated re-ops. I'm often jockeying for position, but my general position is to sit opposite the muscle operated. I have a better view, and there's a consistency with respect to handedness. I never have to backhand a suture because I'm sitting at the top and wanting to go this way. And I just think that I like to have everything working in my favor. Yes, I can do the other. I think it makes it unnecessarily difficult. Magnification. I don't use standard loops. I think there's a benefit to high magnification. Most people, standard loops are 1.8 or 2x. But I don't use the microscope either. I like the magnification of the microscope, but I don't like the immobility. As I said, I like to move around and change position. So I would use high-powered loops. There are various, Zeiss makes them, Designs for Vision makes them. These are 3.5 or 4x loops. They're basically head-mounted microscopes. a lot of magnification, and I have the mobility that I like. A few words about refractive correction and amblyopes. If it's an accommodative VT, I give full plus meaning under cycloplegia. If they're not an accommodative VT, I always give full correction to myopes. With hyperopes, I'll cut the plus about 1/2 to 1 diopter. Why? Well, there's no data for this, but I think that there's some indication that completely eliminating accommodation may impede emmetropization. So my logic, and I follow the dictum, when there's data that's good, I follow it. And when there's no data, I do what makes sense. I like patients to be accommodating about the amount a normal child for age would be, which is about 1/2 to 1 diopter hyperopic. And certainly if there's amblyopia, I don't want to cut it too much because amblyopic eyes don't accommodate as well as normal eyes. I'll aim more for the 1/2 a diopter. But you have to balance anisometropia. You have to cut plus symmetrically if you cut it. When I measure a patient with a high refractive error, here's a lady who's a -30, and she measures 45 ET. Question is, do I operate for 45? No. She's actually 26 prism diopters esotropic. And that brings up the subject of spectacle-induced prism. If we look at a myopic concave lens, and here's an esotropic eye, so it's not looking through the optical center, it's looking through the nasal aspect of the lens. This has the configuration of a base-in prism. So the spectacle is like adding base-in prism, which will increase the measurement that you get with cover test in an esotrope. And there's every combination. An esotropic hyperope, it'll induce space out, like a converse of what I just said. An esotropic myope, which is the example I just gave, induces base in. Conversely for exotropes. I actually keep this table. It is in my textbook, and it's available in print. I think it's the Orthoptic Journal. And I would consult this regularly. It was in my exam room. Actual deviation in prism diopters, that's what they really have. And this is what you measure, depending on what the spherical equivalent is. So if they're a -10 and I measure 25, they're really 20. And of course, with spherical equivalent, you have to take into account is they're the astigmat and what's the spherical equivalent, the horizontal meridian, and so on. But small, this doesn't become significant until you're up around 5 diopters. So you'd have to have a huge amount of astigmatism before that would make a difference. And this is something I would consult regularly. Okay, what do you do if you have a patient that needs vertical and horizontal deviations offset with prism, and you want to get one Fresnel over one lens because you don't want to blur the other eye? You could obviously put horizontal in one eye, vertical of the other, but prefer to not do that if you can. So let's take a patient, hypothetical, 10 ET, 7 of hyper. You want one Fresnel. How do you calculate it? I'm going to give you several ways to do it. Perhaps the most accurate, but just technically, it's a little harder to get patients to understand this and cooperate. But the most accurate is something called the Tangenelli vector. You put the trial frame on the patient and you put a red lens, a clear red lens over one eye and a white Bagolini over the other. And you shine a pen light at them. And what do they see? Well, they see one red light and one white light. And the white light has a line going through it. So we've got a vertical and horizontal deviation. Then what you do is rotate the Bagolini lens so the line formed by the Bagolini lens connects the white and the red together. That gives you the axis, the base where you want to put your prism. Then you take a horizontal prism bar and run it in front of this eye perpendicular to that axis. So you got to move the light closer, closer, closer. Bingo, they're together. That prism is the amount of prism you want, and this is the axis where you put the base. Now, if you can do it, that's the most accurate. Another way is you could do a vector diagram. You just 10 and 7. So lay out, make a 10-inch line and a 7-inch line, or centimeter, whichever you prefer, on a piece of paper, and measure the hypotenuse. That's, in this case, it's 12. So you need a 12 prism diopter prism. And then you take out your protractor, and that gives you the axis. And if you haven't invested 15 cents in a protractor, you can fold the corners of the triangle down and hold this up over the trial frame, and that tells you the axis. A word about monovision and strabismus. Now, this is, of course, only an issue in potentially fusing patients. I saw this woman, she was 25 years old, and she had 3 prior surgical procedures for intermittent exotropia. And she was advised to have a 4th. She came to me for another opinion, and I said, so this is a refractive error. She's plano and plus minus 350. I said, where are your glasses? She said, well, I don't have glasses. You don't have glasses? She said, well, no, they told me I'd never need glasses. I'd use one eye for distance and the other for near. And she does, independently. All we did was put her in her proper correction, and after a period of time, she regained control over her deviation. That's the patient. And again, Art Jampolsky, who was one of the greats, wrote a fabulous, fabulous article in the New Orleans Academy Transactions in one of the years that they did strabismus, 1978, called Unequal Vision Inputs in Strabismus. And it's a work of art. I encourage everybody to read it. Give you another example. Boy comes in, intermittent left XT with poor control. He's plus 50 in the right eye and minus 250 with some cylinder in the left eye. Ordered the glasses, but the optician screwed it up and reversed the prescription. He put the minus 250 with the cylinder over the fixing right eye and the plus a half over the left eye. Now, the question I have for you all, just think about it for a minute. Would he be better or worse? Minus, mind you, minus lens therapy helps intermittent exos control. And now he's over minus in his right eye by 3 diopters, or adjusted 2.5, adjusting for the spherical equivalent. Turns out he comes in, his control is worse and his angle's worse. Have the glasses corrected, comes back with an exophoria of 10, and he's stable for 8 years, and then I lost him to follow-up. Here's a vivid example of how detrimental uniocular blur is to bifoveal fusing patients. And I want to just, before I run the video, I want to just point something out. Here's a patient with an intermittent right XT. You can always tell which is the dominant eye by how they refixate. You'll see when we cover the right eye, it goes out. And when I uncover it, it makes a vergence to come in. When I cover his dominant right eye, it goes out. And when I uncover, he makes a saccade to the left, to the right with both eyes to pick up fixation with that left eye, and then makes the vergence to come in. Let's see what minus lens, what we can do with anisometropia. So the first, there, he's an XT. See that? He made a saccade, and then he vergence with the right eye. Right eye comes in, and he's going to do that. I think he does it again here. Absolutely diagnostic. If I hold up minus lenses, in his case, minus 2s, he's able to control his deviation. He had a little refixation there. He's not actually isotropic. But if I hold up minus 2 over his fixing right eye. Now he's over minus. He can't control the deviation. Why? Because he has uncorrected anisometropia. So I hope that convinces you of that. Another nice little pearl. You all know this patient. You say, which is better, refracting? Which is better, 1 or 2? They say, no. You say, well, pick one. And they say, neither. Ask them which is worse, 1 or 2. These patients always love telling you which is worse. And when I first heard this, I thought it was a joke. It really works. I did this on my mother-in-law. She was one of these, she could not pick one being better. She could always tell me which was worse. And I'd encourage you to make use of that. Dynamic retinoscopy, this is a technique that is not widely used and it's useful. It's not doing a dry refraction, but it's done in the uncycloplegia, the dry state. So what you need, patients, it's dry, not dilated. You need a fixation target, preferably accommodative target, on the retinoscope, and you hold it right under the light. You have the patient fixate in the distance while you're streaking, and then you have them shift fixation to a near accommodative target and continue streaking them. And you do that for several seconds. The normal response, if they are fully accommodating on your near target, regardless of what their refractive error is, if they have overcome it and they're accommodating, you will see the retinoscopic appearance of neutrality. And the normal response to simulated accommodation is a brisk change to neutrality, and it should be sustained. Subnormal accommodation you'll continue to see with motion on retinoscopy, or you'll see a sluggish response. It takes many seconds to get to neutrality, or it's not maintained. Now, what is the utility of this? Well, you could tell about accommodative insufficiency. If you have a neurologically impaired child, particularly if they're not verbal, may help you determine if they need a bifocal for visual purposes. Down syndrome, many have decreased accommodation, and it may tell you if they need full hyperopic correction because they're not accommodating, and it can tell you about the need of a bifocal. But the other great use for it, in my mind, is if you have an infant who's ortho with significant hyperopia. So what do you do? Patient came in, the vision screening, or your sibling of a patient, asymptomatic, they're ortho, and they're +4. And of course, maybe a family history of strabismus would influence you, but let's say there isn't. Do you give them glasses? And are they at risk for getting, for going esotropic? Well, a very good study done, it was a prospective study, had hundreds of patients, done in Turkey by Denise Sommer, said that in these patients, if dynamic retinoscopy is normal, that means they're fully accommodating, despite their +3 or +4, they're fully accommodating and they're still ortho. You can observe them, they don't go esotropic. Whereas if you do dynamic retinoscopy and you still see with motion, meaning they're not fully accommodating, either they're going to develop an esotropia, they get a little older, they want clear vision, they start accommodating then they go esotropic, or some develop bilateral refractive amblyopia. So I think that's a useful tool. And with that, I think it's time to end this lecture. We're pretty much on schedule, and we could take some questions or move into cases if you like.
There's a question from Dr. Rubat.
Thank you, Dr. Kushner. Very, very interesting talk. Deviations from the norm, but very interesting. Your suturing technique for recession, it's not clear to me. Can you please explain again?
Yeah, I probably shouldn't show the slide because I realize I'm not going to convince people to use two sutures, but just to explain it, it is explained in detail in my textbook. Muscles on a hook. I put a suture at the insertion, the middle of the muscle, weave it to, let's say, the inferior corner, put a lock bite in. So it's double arm suture. Then I take another suture, put it just adjacent to that one at the middle, weave it to the other corner, put a lock bite in, cut the muscle off. Then I put all 4 suture tracks in the sclera.
So in what direction your needles go as compared
The
to
needles go directly toward the insertion. I'm fixating the insertion and I suture toward my hand. I really feel that, to me, suturing is a two-handed technique. I will often, particularly if I'm working way back, there's exposure difficulty, I will help guide my suture depth by raising the globe with my fixation, lowering it, rotating it, and to have the assistant fixating the globe and doing that, I think puts me at a huge disadvantage. I know a lot of people do it and do good work with it.
Yeah.
It's not for me.
Yeah, I don't allow my assistant to fixate glue for me. I fixate it myself.
Good.
I just feel secure. It's like chances of scleral bite there less. Okay, and my other question was regarding Faden. So Faden, you talk about Faden in esotropy of convergent success type, but there are certain other situations where they recommend Faden, like when there is asymmetry in the movement and sometime in DVD. So you don't do Faden for any of the procedure?
So
or
I do Faden when I want to decrease adduction inside or down gaze. So if I want to balance adduction deficit, Faden is perfect, is terrific for that. I've done some Faden for DVD, and I know some people have good results with it. I just think it's technically a lot trickier. And I've never been impressed that, nothing is a cure for DVD. I've never been impressed that the results in my hands or the published hands were better than other things that are simpler. So I don't have a problem with it. If someone is experienced and does a lot of Fadens for DVD, that's great. I just think that it didn't add anything to what I'm normally doing.
Okay, good. Thank you.
Yeah. Okay, and a question from Dr. Aragunla.
You're muted.
That's because I'm speechless. In some ways, that was a phenomenal talk. Really pearls of wisdom, like small, short segments, but really, really nice. And that was the best talk I've ever heard.
Oh.
So, and very practical, and you talked everything from basic science, actin, myosin, and sarcomeres, all the way to prism and using even a paper for a 30-cent protractor. So very practical. Thank you.
Right.
One thing I noticed all of today, at least from what I heard, I never heard you say the word plication. Do you do plications or you don't? Do you have strong opinions?
Thank you. It's a good question, and thank you for bringing it up. I'm emeritus. I no longer do surgery. I stopped operating around 2012. The way I can remember that it's 10 years ago is one of the very last patients I operated on. Actually, the last day, she was my second to last case on my last day, was the 5-month-old daughter of a good friend. So whenever I see him, I say, how old is Madeline now? He says, oh, she's 10. Oh, I stopped operating 10 years ago. Plications became popular in this country. I'll call Canada this country, around the time I stopped operating. So I had very little personal experience with it. I did some. I think it's interchangeable with resections. And I think, I'm glad you brought that up. Anywhere in the talk that I said resect, you can substitute the word plicate. I think that from the the muscle physiology point of view, they do the same thing. I know some people say one of the formulas is a millimeter different or something like that. I don't have personal experience with that. But as far as what you're doing, a recession weakens a muscle, a resection and application, they do the same thing. They put the muscle on stretch. It's just in one case, you're throwing away the material and the other, you're folding it over. So I think plications are great. And from what I understand, they will probably completely replace resections. But I didn't. I had to add that to the talk because it's a good question.
So you think they will one day replace resections? Like there's some people who say that, and I've probably seen this too, over the years, plications tend to kind of, there's some regression and you tend to see like a bit of undercorrection.
Well, again, I don't have personal experience with it, but I will also say same problem with resections. Resections come undone. If you can resect a lateral rectus 8-9 millimeters, and if you go back years later, you could resect another 8 or 9 millimeters. Sarcomere remodeling, or maybe 6 or 7. It's not that tight muscle it was at the end of the procedure. Sarcomere remodeling, it adds sarcomeres and it lengthens. So I think resections also wear off. I'd like to see, when people talk about that happening with plications, I'd like to see a comparison, a study comparing resections to plications. I think they'll find the same thing with both, at least based on what I understand what's going on. But again, I just don't have personal experience with it. But there's no question that resections tend to wear off with time also.